morning, everyone. Welcome to our breakfast at UMHealth today. Today is a special sessions for the Faculty of Medicine's Best Neuroscience Publications for the year of publications in 2020. And we have two speakers today. Now I'd like to invite Dr. Yong to present her presentations.
Hi, a very good morning to all of you. It is my honor to receive this award, and I would like to special thank my supervisors, Associate Professor Dr. Tan Ai Hui and Professor Lim, to guide me throughout this process and to bring me to where I am today. So, actually, my research is about body composition, sarcopenia, and frailty in Parkinson's disease. It is a 3-year longitudinal cohort study done in 2015 to 2018. Parkinson's disease is the second most common neurodegenerative disease after Alzheimer's, which affected about 1% of individuals more than 60 years old. It is a disease affecting the dopaminergic neurons of the midbrain at the substantia nigra pars compacta, and the etiology is multifactorial. It is a clinical diagnosis with 4 cardinal signs, which are the bradykinesia, resting tremor, rigidity, and at the later stage, postural instability. This is a video of one of our Parkinson's disease patients from University of UMMC. From here, you can see that is a resting tremor of right hand, bradykinesia, where there is a reduce in amplitude of the finger tapping and hand movement, and you can see there is a jaw tremor, difficulty in arising from chairs, and there is a shuffling gait with reduced arm swing and turning end block. So apart from motor symptoms, Parkinson's disease has a very complex and multiple non-motor symptoms, including the weight loss. Even before the onset of motor symptoms manifest and Parkinson's disease get diagnosed, there is a prodromal phase where the non-motor symptoms happen, which is a period where the brain pathology happen outside from the substantia nigra pars compacta. And as disease progresses, the disability worsen. And the major cause of disability in Parkinson's disease is non-motor symptoms which are not improved by levodopa as compared to motor fluctuation and dyskinesia. Unintentional weight loss is highly prevalent in Parkinson's disease, which primarily happen at mid-stage of the disease. Knowing that weight loss is associated with a lot of negative outcomes, from more severe Parkinsonism, osteoporosis, decrease in quality of life, and increased dependency, and even death. However, this condition is very difficult and challenging to manage due to the etiology factor is still poorly understood. And the contributing factors, part of the contributing factors could be due to gastrointestinal dysfunction such as constipation and reduced and cognitive impairment. Knowing that body weight loss brings negative impacts, let's look into the body composition, which include the bone, muscle, and fat mass. And in our study, we focus on muscle and fat mass. In general aging population, body weight decreased with decreased bone and muscle mass, but increase in fat mass, especially the visceral fat as compared to subcutaneous fat mass. And this is a condition called osteosarcopenic obesity syndrome. Aging is a chronic low-grade inflammatory state which leads to dysregulation of mesenchymal stem cells lineage, whereby there is the production of fat predominate and the production of bone and muscle reduce. And as we age, the distribution of fat is more to the visceral fat as compared to subcutaneous fat. And we found that visceral fat is one of the contributor of inflammation due to its anatomical and physiological differences as compared to subcutaneous fat. And how about body composition in Parkinson's disease? Over the years, many studies done with different sample size and different subjects characteristics with different measurements show different results. Mainly, lower body weight correlated with loss of fat mass but not muscle mass in Parkinson's patient as compared to control. Most of the study were done in a cross-sectional study, and so far only three studies done in a longitudinal design, which show conflicting results and few clinical correlations. Again, knowing that weight loss brings negative effects, limited longitudinal study provides limited insight into the evolution of the body composition in Parkinson's disease. I'll move on to sarcopenia and frailty. Sarcopenia is an age-associated loss of skeletal muscle mass and reduction in muscle strength and of physical performance. And frailty is a state of vulnerability to poor resolution of homeostasis after a stressor event. And both are overlapping geriatric syndrome. Over the years, different studies done with different measurements and different algorithms show the prevalence of sarcopenia ranging from about 6% up to 60%, with lacking of clinical correlation. And frailty and Parkinson's disease, the studies of frailty and Parkinson's disease are scarce, with a prevalence ranging from about 30 to up to 70%, with lack of clinical correlations. This condition, both conditions are knowing that both conditions bring adverse effects in the geriatric age group, but there is still limited study in Parkinson's disease. So here brings to our objective to describe the changes in body weight and body composition in PD patient over 3-year studies, and to compare with non-PD controls, and to determine the factors associated with body weight and composition changes, sarcopenia and frailty in Parkinson's disease. So all the patients and corresponding controls from cross-sectional studies done in 2015 were invited for a repeated assessment after 3 years. And all of them underwent a detailed and comprehensive clinical assessment, and Parkinson's disease severity was assessed with MDS UPDRS and Horn and Yahr staging. Body weight and height were measured, and body composition was assessed by whole body DEXA scan to obtain the fat and muscle mass parameters. And the fat mass index obtained further divided into 5 groups according to enhanced classification. And the visceral fat mass was calculated from Android region according to Bauchi's protocols. And subcutaneous fat mass was calculated from subtraction of visceral fat mass from total body fat mass. Skeletal muscle mass index was calculated, and several fasting blood parameters were taken. Sarcopenia was assessed according to Asian Working Group on Sarcopenia algorithms, which is defined as low physical performance by hand grip strength, gait speed, and low skeletal muscle mass index with the cutoff. Frailty was assessed by phenotype models with 5 variables and cumulative deficit models with 6 domains. Move on to the results. We have 95 PD patients at baseline with 18 dropouts. A total of 77 PD patients completed the assessment, and 55 corresponding controls who came for the study in 2015 were recruited. With 8 dropouts, we have a total of 48 controls completed a 3-year study with high retention rate. Our PD patient was slightly older as compared to control, with the disease duration of about 8.5 years at the baseline. As expected, the disease severity indices, the Horn and Yahr, MBS-UPDRS, and motor response complication, and the PD medication requirements significantly increased over 3 years, signifying disease progression. Move on to body weight and composition. There is a significant more patient self-reported weight loss, evidenced by significant change in the weight of about 2.6 kg, with significant reduction in BMI over 3 years. And when looking into BMI classification, about double of patients were classified as underweight. As compared to patients, control have a smaller degree of BMI reduction, with lower proportion of them self-reported weight loss, with the weight change of about 0.6 kg over 3 years. However, we did not find any significant difference in dietary intake and physical activity in both groups at baseline and even at 2018. Looking into body composition, the graph in red is control and the blue is patient. From here, we can see that PD patient had significant lower fat mass index as compared to patients, and it is significantly decreased over 3 years. And when looking into the classification, about half of them had fat mass index less than 10 centile, and about 1/3 of them had a severe fat deficit. The control also showed significant reduction in fat mass index over 3 years, but when looking into visceral and subcutaneous fat mass, patients showed a significant reduction in both parameters, but only subcutaneous fat mass was significantly decreased in the control. For muscle mass parameters, both patients and control showed a significant decrease in both muscle mass parameters over 3 years, but there was no significant between group difference in these changes. Several factors was found to be associated with low body and fat mass, including older age, female, and constipation severity. And lower visceral fat mass was associated with longer disease duration, higher insulin growth factor 1, and lower HOMA-IR score. Progressive loss of body weight and fat, but not muscle mass, found in PD patient as compared to control in this 3-year study, with a stable self-reported total calorie intake and level of physical activities. So far, only 3 studies done in longitudinal design with different results. And the different patterns could be explained by disease stage-dependent weight loss trajectory, whereby Parkinson's disease patients showed weight loss primarily at the middle stage of the disease. It could also be explained by different ethnicity done in different studies, whereby our Asian population found to have a lower BMI, but a higher body fat as compared to the whites. In terms of the topology of fat loss, PD patients showed loss of subcutaneous and visceral fat mass over the years. And this is quite interesting because in the general aging population, visceral fat mass increased instead of decreased. And visceral fat is the most diabetogenic and atherogenic, which is associated with metabolic syndromes. But the clinical implications of loss of visceral fat mass in PD are still unknown. Move on to predictors of body and fat mass. Female was correlated with reduced BMI and visceral fat mass significantly. It could be explained by the difference in hormonal or metabolic regulations, and it is very beneficial. It would be beneficial to monitor the body weight and nutrition status, especially in this group of patients in clinical setting. Another interesting findings which was not reported previously, at 2015, we found that severe constipation was associated with loss of fat mass. And by 3 years follow-up, it had moderate correlation with subcutaneous fat mass. It could be due to consequence from greater disease burden or restriction of dietary intake to elevate the abdomen discomfort. But recently, researchers gained interest in the role of colonic microbiome and metabolome, which has indirect effect in the body composition by the effect of gut mortality and the dietary metabolism. A longer disease duration was correlated with reduced visceral fat mass significantly, but a recent study found an association between low android fat and worse motor performance in a relatively early stage disease. Higher IGF-1 and lower insulin resistance correlated with decreased visceral fat mass. IGF-1 is an anabolic hormone which helps in insulin sensitivity and lipogenesis, but it may contribute to lipolysis in the starvation state. Move on to sarcopenia. The prevalence of sarcopenia is significantly higher in PD patients as compared to control, which was 28.6% versus 4.2%. With increasing age is the main predictors of sarcopenia. At baseline, we did not find any significant difference in the prevalence of sarcopenia in both groups, but a larger and significant difference emerged by 3 years, with increasing age was the main independent predictors consistent with these two studies. Likewise, the prevalence of frailty was significantly higher in PD patients as compared to control by both phenotype and cumulative deficit models, with increased age and worsened cognitive function being the predictors. And so far, there was no longitudinal study on frailty and Parkinson's disease, and the different factors found in different studies. So here come to my conclusion. In this 3-year longitudinal study, PD patients showed progressive loss of weight and both visceral and subcutaneous fat, but not muscle mass, with more than a quarter of patients developing sarcopenia and up to 3/4 were classified as frail. We have identified several risk factors with these changes, including the constipation severity and markers of insulin resistance. With that, I would like to end my presentation with a video of the... With that, thank you everyone.